Hello, my name is Sarah Richter, and I am the volunteer for the MAVEN Project. Thank you all for joining us today and our friends at this clinic for hosting today's session. When to order an echocardiogram by Dr. Robert Master. Just to give you a little bit of background information about Dr. Master, he is currently an adjunct clinical associate professor in the Department of Medicine at Stanford University School of Medicine, where he focuses on teaching the next generation of physicians about bedside medicine, critical thinking, and the art of diagnosis. For over 30 years, he was an interventional cardiologist in a large multi-specialty group with a practice that spanned from general cardiology to imaging, echocardiography, nuclear cardiology, CTA, EKG, including treadmills, Holter monitoring. This also includes pacemaker and AICD implantation, in addition to invasive angiography and coronary interventions. Dr. Master's areas of expertise extend to all topics of general cardiology.
Dr. Master, when you're ready, please begin.
Okay, so the first slide is a disclosure slide. I have nothing to disclose. The accreditation, as you understand that this activity is available for 1 CME. So we'll talk about the common echo indications, and this is transthoracic echocardiography. I think if someone needs a transesophageal, that should be really the purview of a cardiologist. So we're not going to really talk about that particularly. As I was looking at these slides, I realized that a lot of this is sort of an overview of a lot of different topics in cardiology. So we'll digress from time to time. And please feel free to either interrupt me, and if you have questions during the presentation, it's fine. Or I'll leave time at the end so that you'll be able to ask any questions you might have based on the overall presentation. So the whole idea of this webinar is to give you an idea of when you should order an echo. And I think to take a step back, the first question is why order any test, not just an echo? And I think, first of all, it's to determine if you're going to order a test, if it's going to change someone's treatment. Number two, you're going to order a test for diagnosis, or number three, for someone's prognosis. So test ordering is not for curiosity. It's for a particular reason, and we're going to go into the particular reasons that you might order an echocardiogram. So we'll first start with the kind of symptoms that would make you think that an echo would be a helpful test. And realize there are just 4 symptoms in cardiology: chest pain, palpitations, dizziness, and shortness of breath. So that's it. I mean, if a patient doesn't have any of those symptoms, it's very unlikely that something cardiac is going on, but we'll talk about 1 or 2 other reasons why you might order an echocardiogram. So the most common indication from a symptomatic standpoint is shortness of breath or a change in exercise tolerance. So someone says to you, gee, I used to be able to walk up a certain hill or at a certain pace, and now I know I have to stop. I have to rest. I can't get up the hill. And I think that there are 2 types of patients. One type will continue to do what they've always done and have symptoms, but you have to also be aware that there are certain patients who, knowing they have symptoms, will avoid that activity and say, oh, I have no symptoms. But then when you talk to them, you find out they're mainly, to use a colloquialism, they're a couch potato. They don't do much. They don't do so a year or 2 or 3 or 4 years ago, they might have been very active, or they might have even been doing marathons. They have no symptoms now, but they're not doing anything because they know when they do something, they have problems. So I think to get at this idea of symptomatology, you have to find out, have things changed at all in either the recent or the remote past. And when you talk about shortness of breath, the first thing that comes to mind is heart failure. And as you know, these days, there are 2 flavors of heart failure. There's heart failure with preserved ejection fraction, and heart failure with reduced ejection fraction. And the echo is fairly diagnostic of the reduced ejection fraction because you get an ejection fraction measurement when you do an echo. Heart failure with preserved ejection fraction is a much harder diagnosis, not just for primary care physicians and providers, but also for cardiologists. So there are things that suggest that diagnosis, but aside from a invasive catheterization in which you measure an increase wedge pressure or left atrial pressure, either at rest or with exercise, everything else is inferential and not diagnostic. So a number of things that we'll talk about on the echo, which suggest heart failure with preserved ejection fraction, are specific. That is, they're often seen in people who have heart failure with preserved ejection fraction, but they're not sensitive. Not everyone has these particular abnormalities. So, the most common of the things that you'll see is a thickened left ventricle in heart failure with preserved ejection fraction. The second is left atrial enlargement or increase in left atrial volume. So if the volume is greater than 34 millimeters per millimeter square, either that single dimension or the area will give you an idea that something is abnormal, because the left atrium usually is not dilated unless there's a volume or pressure overload. What else? Well, if people have elevated left ventricular end diastolic pressures, they may develop secondary pulmonary hypertension, which is readily measured on an echocardiogram. Lastly, there are Doppler indices of diastolic noncompliance. But diastolic noncompliance is very common as people get older, and heart failure with preserved ejection fraction is common as people get older. The bottom line is you can have diastolic noncompliance and not have heart failure, and heart failure with a preserved ejection fraction and not have diastolic noncompliance. So those findings are helpful when present, and the more of them that are found, that's very helpful. But finding those doesn't prove one way or the other the person does or doesn't have heart failure with a preserved ejection fraction. So what are some of the things that people look at? And some of these are more technical. And I mention them mainly not because you're going to be reading the echocardiograms, obviously, but you're going to be getting reports that suggest that there's an abnormality. So what are the things to look for? So one is called the EA ratio. And normally you have an M-shaped complex during diastole of mitral valve inflow. And normally there's passive filling of the left atrium, and then there's the atrial kick, and the pressure that results in the mitral valve opening is caused by the E wave, and by atrial systole, the A wave. So if the left ventricle is normal left ventricle, you see the A wave is greater than the E wave, and people with diastolic compliance, that can be reversed. The second thing is what's called the EE prime ratio. And this is a ratio between the early diastolic transmitral inflow and the mitral annular tissue velocity. This is a strain measurement. And if it's over 9, that is strongly suggestive of an elevated left ventricular end diastolic pressure, and therefore heart failure with preserved ejection fraction. You'll sometimes see reversal of pulmonary flow. Normally, pulmonary flow should be in one direction from the pulmonary veins into the left atrium, but if you have high left atrial pressure, the flow can be reversed. You can also see some changes in strain that we won't get into, but any of these parameters of diastolic noncompliance may or may not be present. And one article I saw gives you a risk score of heart failure with preserved ejection fraction that I found easy to remember because, the other thing that heart failure with preserved ejection fraction is called is HFpEF, right? HFpEF. So they said H2, H is the person's heavy and has hypertension. So that's what H stands for. F is for atrial fibrillation. P is for pulmonary hypertension. E is for elderly over 60. And F is for heart failure. And this is the E prime ratio greater than 9. So the more of those things that someone has, the greater the risk that they have HFpEF, and the lower the risk, the less likely it is. And the point is that there's nothing here that's pathognomonic or 100%, but it's a matter of index of suspicion. The other things that are on here with shortness of breath, pulmonary hypertension, and mitral valve disease. Mitral valve disease is pretty self-evident, either MS, mitral stenosis, or regurgitation, or some combination of those two, if they're significant, can cause shortness of breath. Pulmonary hypertension, one way of thinking of pulmonary hypertension is to think of precapillary, capillary, and postcapillary causes, because the echo will not only document pulmonary hypertension, but hopefully help you in many ways separate between those three. So precapillary pulmonary hypertension just means a left to right shunt. So if someone has an atrial septal defect, a ventricular septal defect, a patent ductus, that can cause increased left to right shunting and flow and pulmonary hypertension on the basis of flow. Intrinsic, so capillary pulmonary hypertension just means there's a decreased cross-sectional diameter of pulmonary vasculature, like you can see in a pulmonary embolus or due to chronic pulmonary disease. So it's almost anything that can cause cor pulmonale is by definition a cause of capillary pulmonary hypertension. And postcapillary refers to mitral valve disease and left heart failure. So depending on what you see on the echo will help you determine whether there is pulmonary hypertension and possible causes. So that's just talking about shortness of breath. An echo will give you a tremendous amount of information about the possible causes or potential causes and possible etiologies. The second thing is chest pain. Now, this is really relates to chest pain that's non-anginal. Anginal chest pain is pretty clearly exertional, relieved by rest and/or nitroglycerin. More commonly occurs in the morning, more commonly occurs on a full stomach or when you're carrying things. That's not what we're talking about here. That's a clinical diagnosis that you can obtain from your history. People often have other types of chest pain that are disconcerting. So someone, for example, someone has non-anginal chest pain, one possibility is dissection. So for example, at one point in my career, I saw a young woman who was on her son's kindergarten class trip to the hospital, where she suddenly developed chest, arm, and abdominal pain. And she had a dissection of her aorta from the root down to her iliacs. So that's one. So you can see a false and a true lumen in someone who has dissection. Pericarditis. So you realize pericarditis doesn't necessarily cause any abnormalities on the echo, only if there's an effusion. So a pericarditis early on without effusion will result in a normal echo. So what you see, though, if you see someone with pleuritic and positional pain, pain that's worse with recumbency, with lying down, pain that's worse with inspiration. An echo will let you know if there's an effusive process as well. The next thing is a hypertrophic cardiomyopathy. So let's say someone gives you a history of what sounds like exertional chest pain, but they don't have cardiac risk factors. They're not particularly old. Maybe they have a hypertrophic cardiomyopathy in which there's typically disproportionate septal thickening, but other things as well. We're going to come back to this because echoes are also used in screening of first-degree relatives, as this is typically an autosomal dominant trait. And one of the priorities of patients with hypertrophic cardiomyopathy is to screen out and find other family members. Lastly, what about the patient post-MI who's having chest pain? And there are a couple of concerns there. One is that the person has not finished with their infarction. Sometimes it's a Dressler syndrome, post-infarction pericardial effusion. In some cases, it's due to a perforation of the heart, and this would be something that would happen during the hospitalization, where we call it a perforation, but actually what happens is that the blood dissects from the chamber of the left ventricle into the pericardium in a very serpiginous way, and typically results in a very in a pericardial effusion, which early on is loculated, and then becomes can result in tamponade. So it's, and the other term for that is a pseudoaneurysm. So these are all, so someone who's had a heart attack and is having chest pain, that requires an echocardiogram. So the third symptom that people have, we talked about chest pain and shortness of breath, is palpitations. And what we're interested in is, does the person have structural heart disease? So in the absence of structural heart disease, our concern about a significant arrhythmia is less, not zero, but certainly, for example, if someone tells you they have sustained palpitations and dizziness and you find that the person has a decreased ejection fraction, that's very different than someone who has palpitations who's 20 years old and has a normal left ventricular function. So it's the association of arrhythmias and sudden cardiac death really have to do with whether there's typically structural heart disease, unless they have some underlying pathological substrate for arrhythmias per se that are independent of it being structural. So structural heart disease is helpful. Lastly, dizziness and syncope. And dizziness and syncope may or may not be a precursor to sudden cardiac death. So you can see SHD, structural heart disease, sort of as an echo a little bit of number 3. If people have pulmonary hypertension, they can have exertional dizziness and syncope. They can have the same thing in a hypertrophic cardiomyopathy. We'll see this when we put them on a treadmill. They'll become hypotensive due to left ventricular outflow tract obstruction, typically. You can see the same thing in aortic stenosis, in which people have exercise-induced hypotension. And then some people with arrhythmogenic right ventricular dysplasias will have enlargement and aneurysmal dilatation of segments of the right ventricle. So those are the 4 common symptoms that people present with heart disease, but there are 2 other things that are not typical cardiac symptoms that would make you get an echocardiogram. One is a fever, and typically a fever of unknown origin. The question is whether the heart is the cause of the fever. So things that would make you particularly concerned would be, in addition to an FUO per se, is if the person had some implanted cardiac device, a pacemaker or defibrillator, and the concern is, does the person have a an infection of their chronically implanted electrical device? Does the person have pre-existing valvular heart disease upon which is superimposed endocarditis? Is the person an intravenous drug abuser? Does the person have any evidence, in addition to a fever, of peripheral emboli or peripheral stigmata of endocarditis, which I'll talk about in a little bit? And lastly, there are certain organisms that suggest endocarditis. For example, strep viridans suggest endocarditis. Staph, in about 25% of cases, is associated with staph bacteremia is associated with endocarditis. Staph frequently affects the valves, and it doesn't have to be any underlying valve pathology. So, the duration, even if you have staph, and obviously you're going to treat that, the duration depends on whether or not there is, in fact, an established valvular pathology, because you're going to treat that longer for staph sepsis. Obviously, if there's a valve involvement versus, say, just a staph due to an indwelling catheter that you've removed. Also, yeast infections, Candida albicans. I think if that grew from a blood culture, you almost inevitably need to do surgery on that valve to remove the focus of infection. So certain organisms in particular would make you want to get an echocardiogram. Lastly is a stroke or a TIA, particularly in someone who's not in the typical age group. So we'll say someone under age 55 or 50. And I would strongly recommend, especially in a young patient, to do a bubble study. And when you order it, and the question is, what's a bubble? What's a bubble study? So what you do, and this is how we would do it, we would take a syringe, 10 cc's of saline. We would start an IV on a patient before an echo. You shake up a 10 cc syringe and that creates micro bubbles. You don't have to actually have bubbles that you can see, but when you agitate and shake up a 10 cc syringe, it acts as echocardiographic contrast. And as you're echoing the intraatrial septum, you inject the 10 cc's very rapidly. And what you'll first see is it looks like a bunch of white mosquitoes in the right atrium and then the right ventricle. And then typically you see nothing because the microbubbles are filtered out by the lung. But if you see those little white microbubbles going from right to left at the atrial level first, there's a right to left intraatrial shunt. If you see the bubbles first cross over at the ventricle, there's a right to left shunt at the ventricular level. Now, obviously, any kind of shunt from the right to the left atrium is going to eventually fill the left ventricle too. It's where you first see the microbubbles. So if you don't order a microbubble study in someone with a cryptogenic stroke, they're not going to do it. You have to have an IV started before the study. So it's a simple study to do. There's no real risk to the patient. As I mentioned, these are microbubbles created by agitating 10 cc's of saline and injecting them rapidly. But that's really the best way of ruling out a patent foramen ovale. You can have a stroke from mitral valve disease that's occult, and sometimes it's hard to hear the mitral stenosis or mitral regurgitation because it's only best heard over the apex or in the axilla, and it may only be heard with the patient lying in the left lateral decubitus position. So if you have someone with a stroke, if you're still clinically oriented, as I am, I would always roll the patient on their left side and listen carefully for a mitral murmur. Next is you can sometimes see mural thrombus, and you can see, for example, if someone has a left ventricular aneurysm, that is an area of A, or dyskinesis, which doesn't contract or contracts paradoxically when the rest of the left ventricle, that's an area of mural thrombus. You can also get merantic endocarditis in someone with diffusely metastatic disease, where you'll see thrombus in areas that normally are aren't closed. You'll see thrombus on valves and in chambers that are anatomically normal. Masses, most commonly an atrial myxoma, can present as a stroke or peripheral emboli. And lastly, dissection that involves the cerebral vessels can result in a stroke. So we've just spent a bit of time just talking about symptoms. And so if you just keep in mind that if someone has symptoms that may be cardiac, a fever, or a stroke, those are all reasons for a transthoracic echo. What else? Well, what if someone has a history of congenital heart disease, which may or may not have been repaired? I think one of the questions is, does the person have residual disease that's either the repair was incomplete or the person still needs, and it's known that it's a multi-stage repair. So if someone has an atrial septal defect, you may get an echocardiogram, or excuse me, an EKG that still shows, for example, right ventricular enlargement or an incomplete right bundle branch block. You may not be sure about the splitting. So you may want to see, is there a residual left to right shunt? And this is true of a variety of other congenital heart disease. So I think anyone with congenital heart disease, with or without a repair, should have an echo at some point in follow-up to see what's residually going on. Next is hypertrophic cardiomyopathy. Either you suspect that in the patient or there's a family history. So the current recommendations, guideline-wise, are if the patient, let's say a primary relative, you're seeing a primary relative, it's been recommended that they be screened. The recommendation is to do an echocardiogram if they're under 20 every 1 to 2 years, and if they're over 20 every 3 to 5 years. However, as you can imagine, this is going to run up a bit of a bill. So another approach to this would be to do genetic testing on the person who has who's been proven to have a hypertrophic cardiomyopathy, and then do the genetic test on the patient who is a primary relative. So that's another way of sort of sorting that out without doing an echo. Nevertheless, even if they have that genotype, they're still going to need follow-up echocardiograms periodically to determine whether they have that phenotype. Next is if the person has a family history of sudden cardiac death. So if you get a history that, someone's father or mother died in their 40s and you're seeing the patient, one of the things that you're looking for is, does the person have a hereditary cardiomyopathy? And does that person have structural heart disease of any type? Obviously, you're going to get an EKG as well. But an echocardiogram would be very helpful in that kind of patient. Next is a patient with a pulmonary embolus. And especially if you're concerned that they might have residual pulmonary hypertension. So as you know, most people with pulmonary emboli resolve the pulmonary embolus, do not develop pulmonary hypertension. But a certain subsegment of people do not lyse the clot and develop vascular thromboembolic pulmonary hypertension. So, for example, signs of that might be an increase in the pulmonic component of the second heart sound or left parasternal heave. So what I try to teach my medical students is if you press the palm of your hand on the patient's chest, you'll feel this upward heave, and the right ventricle is an anterior structure. And if it's under a pressure overload, you'll notice that just to the left of the sternum, there's a rise and fall with each heartbeat. So a left parasternal heave suggests right ventricular pressure overload. So if someone's had a pulmonary embolus, that would be a reason to do an echocardiogram to see if they still have residual pulmonary hypertension. An echo, this gets to number 11, is the best non-invasive test for pulmonary hypertension. We talked about precapillary, capillary, and postcapillary causes. And so the echocardiogram not only will confirm or not a suspicion of pulmonary hypertension, but also give you insights as to what might or might not be causing that pulmonary hypertension. Number 12 is you suspect the person has valvular heart disease. And similar to number 7, even if they've had prior valve repair replacement, you want to know, where are they now? How's their heart function? How's the prosthesis? How's the repair? One of the echo is particularly helpful with suspected valvular heart disease in patients with aortic insufficiency. It's helpful with all valvular lesions that are suspected, but aortic insufficiency can be due to 2 main causes. It can be due to either a bad valve, or the valve may be perfectly okay, but the aortic annulus is dilated because of a dilated aortic root. And obviously the treatment of that is very different than just a bad valve. So someone with aortic regurgitation, you want to know, are the leaflets just being pulled apart and the problem is one of aortic root dilatation, or is there intrinsic disease of the leaflets themselves? Next is a patient who either has known or is suspected of having Marfan syndrome. I'm not going to go into a lot into Marfan's syndrome and how to make that diagnosis, but from a cardiologist standpoint, there's really just 2 issues with a Marfan's patient. Otherwise, it's more of a musculoskeletal thing or an eye problem with a dislocated lens. The issue is, do they have mitral valve prolapse and or significant mitral regurgitation? And do they have aortic root dilatation, which can result in either an aneurysm, dissection, or aortic regurgitation? And the current guidelines are to replace someone's aortic root prophylactically if it's more than 5.5 centimeters, but in someone with Marfan's, if it's greater than 5 centimeters. Normal is less than 4. So an echocardiogram should be part of the evaluation of someone who either has Marfan's or a form thrust of Marfan's, a variant of that. I mentioned earlier in this presentation seeing a young woman who dissected from her ascending aorta to her garden tour of the hospital. She did not have Marfan's, but she had the aortic root of someone with Marfan's. And this had to be successfully replaced in stages over quite a few years and decades. Suspected hypertensive cardiovascular disease, initial evaluation or a change in their status. So if you think about high blood pressure, when we measure someone's blood pressure, that is something that is a surrogate marker for what we really care about. We don't really care about a blood pressure per se of 150 over 100. What we care about are strokes, that is brain manifestations of high blood pressure. We care about retinal bleeds, ocular manifestations, kidney failure, which is the kidney manifestations, and heart failure, which is a cardiac manifestation. So you see someone with high blood pressure, if it's marginally elevated, that's one thing. But, you see a blood pressure, you're wondering, is it a white coat syndrome? Does the person really have high blood pressure? They're overweight. If you see left ventricular hypertrophy that may or may not be suggested on the EKG, or maybe suggested on the EKG, but an EKG has not 100% sensitivity and specificity. An echocardiogram will show you, is there left ventricular hypertrophy or not? And certainly, I would say that a patient who has hypertensive cardiovascular disease, that is left ventricular hypertrophy and or left atrial enlargement and or evidence of impaired diastolic relaxation, that patient probably should be treated more aggressively than a patient who just has a high blood pressure number or surrogate marker, because what that's shown you is that the high blood pressure is actually damaging that organ. And it's not just a number. It makes it hopefully more real to the patient, so hopefully they're more compliant. And that this is, compliance is an issue both, I think, for patients primarily, but also for doctors. So someone who has hypertensive cardiovascular disease, that information should be transmitted to the patient. That should be a wake-up call to the patient and hopefully the doctor that blood pressure number really does need to be treated and treated aggressively. And lastly, in someone who has cancer, a number of the drugs have cardiotoxicity, and one way of monitoring them is with an echocardiogram. And depending on the drug and the dose, there are different recommendations, which you can likely Google, that'll tell you how often someone needs to be followed with an echo to assess whether the drug is in fact causing left ventricular dysfunction. So we talked about the symptoms based on the history that should make you order an echocardiogram. What about the physical findings? I'm assuming that everyone on this webinar is still doing a physical examination. I know that it's something I try to teach my Stanford medical students, how to do a correct physical examination. If you're not a cardiologist, you often feel less than confident about your findings, so we'll talk about some of these things. The first is a murmur, and obviously if you hear a murmur, the question is it a functional murmur or is it a structural murmur? And functional murmurs are typically pulmonary flow murmurs. They're heard best over the pulmonic area. People tend to, patients tend to outgrow them, but I think what happens is that people get bigger over time. They become more adult-like. And the distance from the stethoscope to the area of turbulence increases, and my guess is we often don't hear it. It's interestingly, if you had a sterile stethoscope, the one place that you almost always hear a murmur is over the pulmonary valve. So if you had a sterile stethoscope and you're doing cardiac surgery, you would hear a flow murmur across the pulmonary valve, but not across any of the other valves. So a typical physiological or flow murmur is a pulmonary murmur. It has an ejection murmur or diamond-shaped quality to it. And so it's heard best at the second left intercostal space, typically in a young patient. But, and I think because some people do have pulmonary valve pathology, an echocardiogram is warranted virtually on almost every patient who has a murmur. What if you hear a click? Well, click could be an aortic ejection click, which is indicative of a bicuspid aortic valve. It could be a pulmonary ejection click, which is evident in pulmonary valvular disease, or it could be due to mitral valve prolapse. So an echocardiogram is helpful. Gallops, either a third or a fourth heart sound. A third heart sound typically indicates a reduced ejection fraction and a volume overload of the left ventricle and diastole, and a fourth heart sound typically has to do with non-compliant left atrium with the timing analogous to a atrial systole. If you hear gallops in someone, of course, children, you can sometimes hear juvenile gallops, a third heart sound, but in an adult, that would, to me, want to get an echocardiogram. Fixed splitting, which is indicative of an atrial septal defect. So what is fixed splitting? So normally, the aortic and pulmonic component of the second heart sounds are virtually simultaneous in exhalation. And as you breathe in, they get further apart. And typically, the aortic component is louder than the pulmonic component. And sometimes you can hear fixed splitting, or you can hear splitting both in inspiration and expiration with the patient recumbent. So the best thing to do in that situation is listen to the second heart sound with the patient sitting, and that splitting with expiration should go away with sitting, and so you'll hear a single second heart sound with sitting, and then you should hear it split when they breathe in. If you hear it split in inspiration, expiration with patient sitting, that's fixed splitting, and that may be indicative of an atrial septal defect, and an echocardiogram is warranted. If you hear an increase in the pulmonic component, so I said normally the aortic component is the dominant one. So you hear a loud first component and a much softer second component. If the pulmonic component is the louder of the two, particularly if you feel a left parasternal heave, you put your heel of your hand in the left parasternal area. That's the area over the right ventricle. That can be indicative of either volume or pressure overload of the right ventricle. Those two things make you think of pulmonary hypertension. And as I mentioned, pulmonary hypertension is an indication for an echocardiogram. What about clubbing and cyanosis? Well, cyanosis is pretty obvious. That's blue. What is clubbing? So if you look at your finger, you will see if you sort of rotate it so you're looking at it in silhouette, the nail bed is pretty much either flat or curved downward, but usually pretty flat. And with clubbing, it should look more like a spoon that's upside down, and the distal portion in particular is pointed downward. So I can't quite do it on my own finger, but if you see someone with clubbing, the question is this due to cardiac causes? It can be cardiac or pulmonary, the two most common things, although occasionally it can be seen in gastrointestinal and other causes. So it's not always cardiac, but the question arising here is if you see someone with clubbing, is there a cardiac etiology? Well, the cardiac etiologies include any cause of either cyanotic or chronic hypoxic heart disease. It can be seen in endocarditis, and it can be seen in an atrial myxoma. So that's kind of what you're looking for in someone with clubbing. If the person is tachypnic, if they don't complain of shortness of breath, but you notice they're breathing more than 18 times a minute at rest as you're examining them. Hypertension, we talked about a little bit. The question is, do they have hypertensive cardiovascular disease? But there are certain things that particularly should trigger your diagnostic curiosity. One is if the person has diminished lower extremity pulses. So for example, I saw a young woman who was in her 30s who was sent to me really for evaluation of a murmur. But in her history, she told me every single time she got pregnant, she had hypertension, preeclampsia is what the obstetricians thought. And she was rather puzzled when I took out a blood pressure cuff for her legs. And the bottom line is this woman had coarctation of the aorta that had never been picked up before, despite 4 pregnancies. She was quite lucky because one of the ways that people present with this is during pregnancy, they have a stroke because of hypertension to the brain. At any rate, if you have hypertension in the upper extremities and hypotension in the lower extremities or markedly diminished femoral pulses, that should make you think, gee, I want to get an echocardiogram to exclude a coarctation. If you see left ventricular hypertrophy on an EKG, if you see left atrial enlargement on an EKG, if you suspect pulmonary hypertension, or you see on a chest X-ray or on anything else from the history or physical that makes you think of either aortic root dilatation or coarctation in conjunction with hypertension. I mean, hypertension is one cause of an aortic aneurysm and aortic root dilatation. So I think that the echo will give you more quantitative information. Lastly, you're doing a physical exam. The patient has no symptoms, but you notice a diffuse laterally displaced PMI. So the PMI is usually the size of a quarter. So 1 inch, 2.5 centimeters. It's usually within the midclavicular line. And so if you feel a diffuse bigger than a quarter, or it's left of the midclavicular line, that means there's cardiomegaly clinically. And one of the trick questions I ask my students is the PMI the right or the left ventricle? And the answer is it could be either. So if the right ventricle is enlarged, the PMI is the right ventricle. If the left ventricle is enlarged, it'll be the left ventricle. People sort of assume PMI and left ventricular impulse are synonymous. They are not. It is a purposely ambiguous term. So it could be the right or left ventricle or both. So an echocardiogram is very helpful in discerning causes of cardiomegaly on physical examination. Some other things on physical exam. Normally, when you see the triad of edema, ascites, and hepatomegaly, you think, cirrhosis. But that cirrhosis could be from right heart failure, chronic tricuspid pulmonary chronic tricuspid regurgitation, pulmonary hypertension, or even constrictive pericardial disease. So it's very easy for these patients to be misdiagnosed. Sometimes a horse is just a horse, but sometimes it's a zebra. And so when you see some with these three things, obviously the most common things is going to be cirrhosis, but not necessarily, because there are no valves between the right atrium and the liver. Any cause of high right atrial pressures, that'll be transmitted into the liver and can cause a hepatic venous cirrhosis. So don't miss that diagnosis. I think at least one echocardiogram is worthwhile. And even in people with a history of alcohol abuse, realize, alcohol is toxic in some patients mainly to the liver, but in other patients mainly to the heart. It seems rare that people have both. I don't know why, but it's certainly possible for someone to have alcoholic cardiomyopathy and right heart failure and liver disease secondary to that. If you notice an elevated jugular venous pressure, so let's talk about measurement of jugular venous pressure. This is something, once again, I also talk to my medical students about. So the sternocleidomastoid joint is 5 centimeters above the mid-right atrium. So when you measure jugular venous pressure, you're measuring from the sternocleidomastoid point to where you see the top of the venous pressure. Anything over 9 is elevated. And you can see that in any cause of right heart failure, including pulmonary hypertension. You can see it also in constrictive disease and tamponade. So if you see someone with elevated venous pressure, that would be a reason for an echocardiogram. If you're not sure about the jugular venous pressure, is it really the carotid pulsation or the venous pressure? There are a couple of things that I teach my students to help distinguish between arterial and venous pressure. One is if you can palpate it, it's likely arterial and not venous. If you can easily occlude it with just a small amount of pressure, it's more likely venous than arterial. Another thing that helps is if you see 2 waves for each heartbeat when you check the pulse, in this case an A and a V wave, that's more likely to be venous pressure. And lastly, as you breathe in, typically venous pressure descends. It doesn't change carotid pulsation. Occasionally in people with constrictive disease, they have what's called a Kussmaul sign, where the venous pressure will paradoxically increase with inspiration. All these things help distinguish between arterial and venous. But if you see elevated venous pressure, the next step is an echocardiogram. Next is a paradoxical pulse or a rub. So just to get back to what is a paradoxical pulse, normally there should be less than 10 millimeters difference between the systolic pressure